Good morning, everyone. I'd like to officially call this meeting of LNO the last interim meeting of 2025 to order. Clerk, please call the roll.
Senator Chambers Armstrong, Senator Berg, Senator Douglas,
Present.
Senator Higdon, Senator Howe, Senator Mays Bledsoe, Senator McDaniel, Senator Meredith,
Present.
Senator Nemus, Senator Nunn, Representative All, Representative Banta,
Present.
Representative Callaway,
Present.
Representative Kleins,
Here.
Representative Dietz, Representative Donworth, Representative Pfister,
Present.
Representative Flannery,
Here.
Representative Gentry, Representative Hampton, Representative Heverin, Representative Huff, Representative Jackson, Representative Kulkarni, Representative Meredith, Representative Neighbors,
Here.
Representative Raymer,
Here.
Representative Smith, Representative Wilson, Co-Chair Rocky Adams, Chairman Cook.
Here, we have a quorum. First item of business is approval of the October 23rd meeting minutes. Do we have a motion? We have a
Second.
motion. We have a second. All those in favor signify by saying aye.
Aye.
All opposed, nay. Motion carried. We've approved the minutes. Let's move right on. We've got audiologist, or first on the board. We have two members speaking on that. If you come forward. Make sure your green light is on your microphone. You may introduce yourselves for the record.
My name is Stephanie Chayesky. I'm the Executive Director of the Academy of Doctors of Audiology.
My name is Dr. Liz Rogers. I'm an audiologist practicing in Kentucky.
Floor is yours.
Thank you. I appreciate the opportunity to speak to you today about the importance of modernizing the Kentucky Audiology Practice Act under KRS 334A through legislation that will soon be proposed by Representative Duval. The proposed legislation takes a conservative approach to modernizing Kentucky's audiology statute to conform with contemporary clinical practices, national standards, and federal and state regulations. This legislative initiative will codify certain activities that audiologists are already authorized to perform in Kentucky through regulation or legal determination, including the following: evaluating, diagnosing, managing, and treating auditory and vestibular conditions, ordering and performing in-office non-radiographic imaging, removing earwax and foreign bodies from the ear, prescribing, ordering, dispensing, and externally fitting sound processors for a cochlear implant or an osseointegrated hearing device, conducting health screenings. Additionally, the planned legislation aims to authorize audiologists to order radiographic imaging as it relates to auditory or vestibular conditions, to order cultures and blood work as it relates to auditory and vestibular conditions, and to administer and prescribe topical antibiotics and antifungals to treat conditions of the ear. These proposed amendments are supported by the education and training that audiologists receive during their clinical doctoral training at programs such as the one at the University of Louisville and at the University of Cincinnati and Vanderbilt University, which also train audiologists nearby. Kentucky faces a growing shortage of healthcare providers. Primary care physicians, nurses, and specialists are stretched thin, especially in rural areas. Updating the Audiology Practice Act to include these provisions will alleviate pressure on the broader healthcare system by ensuring that audiologists can provide services that they are already trained and qualified to deliver. These proposed provisions will not undermine referrals to other specialists. They will only serve to streamline referrals when medically necessary, reducing the time to treatment for patients and eliminating unnecessary barriers that delay their care. This legislative proposal offers a pragmatic, patient-centered approach that ensures the timely delivery of safe, effective, and evidence-based hearing and balance care for the citizens of Kentucky. At this time, it is my honor to turn it over to Dr. Liz Rogers to provide testimony about the barriers to access that her patients currently face and to discuss the importance of updating Kentucky laws to reflect her training and qualifications.
Thank you. And thank you to Chairs Cook and Rocky Adams and members of the committee. I am very grateful for the opportunity to be with you all today. Again, my name is Dr. Liz Rogers, and I am a clinical audiologist and small business owner with clinics in Corbin and Somerset, Kentucky. I am also past president of the Kentucky Academy of Audiology. For those of you who may be less familiar with audiology, audiologists evaluate, diagnose, manage, and treat hearing and balance conditions. In many respects, audiologists are to the ear what optometrists are to the eye. I choose to live and practice in Southeast Kentucky because there is a genuine need there. I've spent more than 10 years caring for patients with hearing and balance problems in communities where specialist care is often more than 2 hours away. My practice offers the only cochlear implant evaluation and long-term cochlear implant management services, the only comprehensive hearing and balance diagnostic and treatment services, and the only tinnitus treatment services within 70 miles. I drove here today and took time away from my patients to come and talk to you about the urgent need to update the Kentucky Revised Statutes governing the practice of audiology. Kentucky statutes have simply not kept pace with the evidence-based practices in the delivery of hearing and balance care. At the same time, Kentucky regulations and policies have been updated in a piecemeal fashion over the years, creating a disconnect in statute. I am grateful that Representative Duvall is committed to advancing legislation in the 2026 session, which will modernize the Audiology Practice Act and improve access to safe and effective hearing and balance care for patients across the Commonwealth. Most of these planned legislative updates will simply codify existing regulations and policies into statute. For example, services such as performing non-radiographic imaging, using a video otoscope or a digital ear scanner, conducting basic health screenings, fitting and managing sound processors for osseointegrated hearing devices and cochlear implants, as well as the removal of earwax and foreign bodies from patients' ears, are just examples of services that I am already authorized to do by regulation or legal determination. That will be included in this much-needed statutory update. Importantly, this legislation will also make statutory updates to authorize audiologists to order diagnostic tests, including radiographic imaging, cultures, and blood work related to auditory and vestibular conditions, as well as updates authorizing audiologists to administer and prescribe topical antibiotics and antifungal medications when indicated to treat conditions of the ear. These statutory updates offer a conservative and responsible approach that reflects the extensive education and training that audiologists receive, and that will help reduce wait times for my patients. To become an audiologist, I completed 4 years of undergraduate study, followed by 3 years of doctoral studies to earn a Doctor of Audiology degree, which is the entry degree for clinical practice. The University of Louisville, right here in Kentucky, has one of the top-tier audiology training programs in the country, as do the University of Cincinnati and Vanderbilt University, both of which train nearby. I am also very pleased to report that the University of Kentucky, not to be outdone, understands the important role that audiologists play in the delivery of hearing and balance healthcare, and has decided to open an audiology training program, which is scheduled to take its first cohort of future audiologists in the fall of 2026. For my patients, these targeted service additions to the Audiology Practice Act will have a huge impact, resulting in significantly fewer unnecessary trips back and forth between providers and much shorter wait times for urgently needed care. For example, there is a clear-cut clinical algorithm for ordering an MRI for a suspected ear tumor, such as an acoustic neuroma, and the results from the tests that I perform and case history offer a clear indication if one is needed. Today, my patients regularly wait several weeks to months to get into a neurotologist or other specialist just to read the audiology test results that I performed and order the imaging. This creates unnecessary risks of harm to the patient and unnecessary inefficiencies and costs to the system of care. If I can order a medically necessary diagnostic test when I identify a concern, we can reduce the time to treatment and ensure that patients arrive at the physician or specialist with clinical information and test results already in hand. By the same token, if I can manage an ear condition with a topical medication, I can relieve symptoms quickly and safely without sending someone on a long drive for something simple. Something, in many cases, they can already order online and use to treat themselves today. From where I sit, from 2 small clinics serving a wide geographic area comprising most of southern Kentucky, this initiative offers a conservative, common-sense approach to streamline the interdisciplinary care that will directly benefit the patients that I treat every day. I respectfully encourage you to support this initiative so that audiologists can do the work we are educated, trained, and qualified to do so that we can serve most effectively as part of an interdisciplinary care team to ensure safe, efficient, and accessible hearing and balance health care to Kentuckians. Thank you.
Okay, thank you all very much for being here. Before we get into questions, and this is in no way, shape, or form a endorsement of what you're doing or condemnation of what you're doing, but this committee, we get inundated with scope of practice right now, and I think it's very important that we hear them out, no pun intended, but it's very important that we air this out during the interim and that all things are talked about. The KMA is not coming up to the table today, but I know they've been in contact with Representative Duval. I just want to make sure that conversations are happening and that we are working towards session and we are working towards agreements on this. So I just want to say that this is obviously their wish list and what they would like to see for their practice act and what's going to happen. And KMA is now aware of this publicly. We all know what's happening and look forward to conversations over the next 60 days as we move towards session. So are there any questions or comments? Senator Douglas.
Thank you, Mr. Chairman. Let me pull this a little closer here. One of the questions I'm continually asking, and this is not necessarily something that is only for you all. I ask this of all those groups that are coming in asking for expanded privileges, because that's really what it boils down to. I always ask the question, since we make the argument that it would allow more people to see docs and and all this other stuff. I mean, those have been made. That's the same argument that has been made for decades, and we have the same issue. So the question I always ask is, I'm looking for the studies and I'm looking for the evidence, Mr. Chairman, of the data that suggests that expanding privileges really increases the number of people who are seeking health care or getting health care in any of those areas. Now, I know we can talk about convenience, but one of my concerns, we're looking at a healthcare system that's failing in this country. And we know that our insurance companies, for the most part, work on risk. That's part of the business model. And so my concern is how all the expansion of privileges is really going to affect our healthcare system, especially in the insurance coverage area where we're increasing risk for our insurance providers. So I guess I'm asking, is there data that would convince me that moving something like this would increase not only the number of people who are matriculating through the system through audiology, but also would tell me that we're improving the health care that we're delivering. Thank you, Mr. Chairman.
Thank you. Do we have any other questions?
Yeah, I can.
Questions or comments, or would you like to respond to that briefly?
Sure, I'll be glad to. Yes, sir, we do have evidence that we can present. I think in this particular case, again, the first 7 things on the list that you were probably provided in your packet are things that audiologists are already authorized to do in this state, in the Commonwealth, through either regulation or by legal determination through the licensing board. The 3 new things that are on the list really amount to reducing time to treatment for the physician or the specialist. So it's about being able to order further testing that would more quickly and readily get a patient onto a different specialist depending on the outcome of that. For example, as Dr. Rogers mentioned, with getting a patient sooner into getting an MRI if they should need one for a suspected tumor. So today what's happening is the audiologist is performing the tests. They're going through already the report and the clinical algorithms to make the documentation and recommend what's being recommended. It's then taking the patient sometimes several weeks or months to get to a neuro-otologist who's reviewing the audiologist's report and saying, yep, they need an MRI, let's go ahead and get that ordered. So what we're suggesting is by the audiologist ordering that instead, the patient's already going to have those test results when they get to the neurotologist. We're seeing outcomes already in places like Maryland, where this is already in place, where it has, in fact, improved time to treatment and has demonstrated actual savings to both the system and in terms of patient lives.
Senator Berg?
Thank you. And again, I apologize for coming in late. So my one concern, when we're expanding who gets to order what, is who is responsible for the data after it has been collected. So let's say, hypothetical case, you have a patient, you order an MRI, that patient never goes on to see a neuro on top of otolaryngology, whatever we're seeing, because whatever reasons, family decides not to take them. Are you going to make it your responsibility to be aware of the ancillary findings and essentially all of the findings on that MRI, even those that are outside the scope of your practice?
Can I answer that?
Yes.
So yes, in my opinion, it would be our responsibility. If we are the ones ordering the imaging, it would be our responsibility to make sure that we obtain the radiologist's report and review it, and then follow up with the patient as well as their primary care provider to let them know what's going on, and then make sure the patient is aware that we are referring them to a neurotologist if that referral is needed. Because sometimes, we order imaging and there's nothing there. They don't need to see the ENT. But I do believe that would be our responsibility to make sure that patient gets where they need to go.
Okay, thank you. That looks like that ends all the questions and comments we have for this issue. Look forward to all working that out with the KMA, Representative Duval, as we move towards session.
Thank you, Chairman Cook.
Thank you.
All right, thank you. Representative Neighbors, as you're moving down to the table with your guest, I believe Representative Kleins has brought a very special person with him today.
Well, thank you, Mr. Chair. He is the Vice President of Stand Energy Corporation, but I'd proudly like to introduce him as my brother, Jeff Kleins. He's in the back. If you could help me welcome him to Frankfurt.
All right, thank you. Obviously, younger brother. Representative Neighbors, if you and your guest, make sure your green button's on, introduce yourself for the record, and you may begin.
Thank you, Chair. My name is Amy Neighbors, and I represent the 21st House District.
Elizabeth Morgan, Executive Director for the Board of Medical Imaging and Radiation Therapy.
Chairman, members of the committee, thank you for the opportunity to present to you today legislation I plan to file in the 26th session. This legislation would update and modernize Kentucky's statutes governing the Kentucky Board of Medical Imaging and Radiation Therapy, the body responsible for licensing professionals who perform medical imaging, nuclear medicine, and radiation therapy procedures across the Commonwealth. The purpose of this legislation is straightforward: to promote effective administration and government efficiency, and to further protect and safeguard the health and safety of the citizens of Kentucky by regulating two medical imaging professions not previously regulated: MRI technology and diagnostic medical sonography. At this time, I'd like to turn it over to Elizabeth Morgan, who is the Executive Director of the Association, to further discuss the details of the legislation.
Thank you. Currently, Kentucky does not require licensure for MRI technologists or diagnostic medical sonographers. This bill closes that gap, ensuring that every professional who performs diagnostic imaging with ionizing or non-ionizing radiation is licensed and held to the same competency standards. A transition period through January 1st of 2028 allows currently practicing professionals to become licensed without disruption to their employment or patient services. After that date, national credentialing will be required for new applicants, aligning Kentucky with nearly every other state that licenses these professions. The bill increases the board's membership from 9 to 11 to reflect the broader scope of professionals now under regulation, adding one representative for MRI and one for diagnostic medical sonographers. This ensures all imaging disciplines have a voice in policymaking and professional oversight. The legislation updates outdated terminology, clarifies the scope of practice definitions, and reinforces the board's authority to issue licenses, investigate complaints, and enforce national standards. These changes improve clarity for practitioners, facilities, and regulators alike. Medical imaging is a critical part of nearly every modern diagnosis and treatment plan. Whether it's an ultrasound in an OB clinic or an MRI in a rural hospital, patients deserve to know their imaging is being performed by qualified, credentialed professionals who meet recognized national standards. This bill ensures that level of confidence and safety for Kentucky patients.
So in closing, this is a non-controversial technical update that has been carefully developed in collaboration with the Kentucky Board of Medical Imaging and Radiation Therapy and professional stakeholders across the imaging community. It modernizes Kentucky's regulatory framework, enhances professional accountability, and ultimately protects patients across the Commonwealth. I would respectfully ask for the committee's support in moving this legislation forward next session. And at this time, Mr. Chairman, if I'd be happy to take any questions.
I have a question. So there is national accreditation for this, and are we meeting those standards now?
So currently, there's no standards in Kentucky for an MRI or sonography tech. So essentially, there is national credentialing for them, and we would basically recognize that as being qualified for a license.
Okay. How many other states are doing it? Do you know?
Currently 8 for MRI and 5 for ultrasound or sonography.
Representative Banta?
How much would it cost someone to get this since they've been performing it
Sure.
until now?
So our current fee for initial license is $100. If someone is already licensed with us, because many of our professionals already hold multiple credentials, they may have a radiography credential as well as an MRI or sonography credential, we would simply ask that they provide us that information. We would add that to their current license. So they would be, if they're currently licensed with us, we would not require any additional fee. They would just simply kind of register that with us. But an initial license would be $100.
Thank you.
Senator Byrd?
Thank you, thank you. So exactly, I've got a couple of questions, if that's okay. What are the requirements for certification for ultrasound and MR? Is there anything above an RT?
No. So with MRI, it's a 2-year, mostly a 2-year program, and then typically an associate's degree, and then they take the certification exam.
Most of our MRI techs are RTs that we train ourselves to do MRI. They do not come through a separate MRI training program.
Okay, and so in that situation, if someone is already credentialed for radiography, then they can do some continuing education and some on-the-job training and then sit for that credentialing exam. But if someone is currently practicing, through this bill would allow that person to become registered with the board, become licensed with the board without holding that national credential. So we're allowing some time for a grandfathering period for those who are currently practicing.
Till 28.
Yes, correct.
Just for 2 years.
Correct.
Okay. I mean, my real concern, honestly, is going to be with sonographers, which we already have a significant shortage and difficulty filling the jobs we have. And I'm just very concerned, particularly in the more rural markets, that this is going to limit quite significantly people's ability to perform, to offer these services. Have you looked into that? Have you looked into the number of sonographers we have in the state? How many you would consider adequately licensed? I mean, you're giving me like they have to take some classes. I don't know how many CEUs you're talking about. I don't know exactly what type of certification you're even asking for, and only 6 and 8 other states in the country do this. What's the purpose?
The board feels that it's a more safe method of these individuals being able to give these exams to the Commonwealth to assure that they are qualified individuals to do that. One thing that is concerning that I'm not sure that you're aware of is we're seeing more portability with MRI as far as someone may be in another state scanning a patient in Kentucky. That's becoming more and more prevalent, and just assuring that the people that are with the patient are qualified to do so, I think is important to the board.
Okay, thank you.
Senator Meredith.
Thank you, Ms. Chair. Very simple question. I'm looking at Section 4. That says if you're not credentialed by January 1st, 2028, do you know how many people that might be?
So I looked at the census for the ARRT, which is the National Certifying Body for MRI. It looks like there's approximately 800 individuals that are currently certified in Kentucky. And with the sonographers, there's about 1,600. Does that answer your question?
That are or are not?
That are currently certified.
Well, how many are not? Do we have any idea?
I do not have those numbers.
I would think when we hear this bill again, if we hear it again, that would be very important information. And if you can kind of stratify it as to whether it's urban versus rural, I would appreciate that as well.
Okay.
Thank you.
Thank you.
Okay, thank you all very much. Some homework to do before session.
All right, thank you.
Representative Bratcher, you want to come forward for the Respiratory Care Interstate Compact?
Thank you, Chairman Cook, and the committee for allowing us to present this potential legislation for next session. So basically, this is a I'm sorry, Steve Bratcher, Representative 25th District.
I'm Tamara McDaniel, the Executive Director of the Board of Respiratory Care.
I'm Stephanie Brothers, the Director of Clinical Education in the Respiratory Program at Elizabethtown Community and Technical College, and the incoming president in January for the Kentucky Society for Respiratory Care.
All right, floor is yours.
Thank you, Chairman. This is a respiratory care interstate compact, basically allowing interaction between the states. If somebody's registered in one state, they can practice in another state if we join this compact. So that's in summary. I will let them explain a little more in detail what it does.
So respiratory therapists, you may not realize what a respiratory therapist does. Pre-pandemic, a lot of people didn't know what respiratory therapists did on a day-to-day basis. Post-pandemic, a lot of people realized either they had a personal family experience or someone you know, whether you worked with them, had dealt with someone that had COVID. But we also deal with chronic lung patients, such as chronic obstructive pulmonary disease or COPD, asthmatic, cystic fibrosis, and patients like that, emphysema. So we deal with the respiratory system, which is heart and lungs, and we deal with patients that interact with patients, premature infants that are first taking their breaths, all the way up through the most elderly patients who take their last breath, and every patient population in between. So as an educator, I'm teaching those students to become respiratory therapists who, all three of us are respiratory therapists and have been respiratory therapists a long time. So we make sure that a lot of us worked in hospitals where we could work in the ICU, the neonatal and pediatric ICUs. We could work in the emergency department. We, outside of the hospital, besides becoming managers or clinical educators, we could work in home care, which reaches out to the rural aspects all of Kentucky. We could work in pulmonary function labs, sleep labs. long-term care facilities, and also through telehealth or in pulmonary physician offices. So, and how we interact with collaboratively with other within the healthcare team is that we work with physicians, nurses, therapists, occupational, physical, speech therapists, and interact and make sure that we can diagnose, treat, and make sure that we give these patients the best treatment possible from inpatient to outpatient and discharge home. So at this time, I'll let Tammy speak to the licensure aspect of it.
Thank you. Thank you, committee, for having us here to hear this. This licensure compact, the Respiratory Care Interstate Compact, is much like other allied health licensing compacts that the state has passed. That includes counselors, dentists, and dental hygienists, occupational therapists. The compact has advantages for all the stakeholders, for patients, especially for military families, state licensing boards, like myself, and the states themselves. Patients benefit by access to care from highly qualified providers, improved continuity of care, and enhanced ability of telehealth services. Military families are the people who benefit the most from this compact. Military families benefit from the mobility for practitioners through the recognition of an existing license. The reduction in barriers for this group to licensing alleviates the maximum amount of time, cost, and effort that they use, which is a lot. I don't know if you've ever talked to any of your military families about what it takes. Now, for the state of Kentucky, our respiratory licensing board is pretty quick. We have them licensed within 48 hours, but that's not true in other states that they go to. So while they might not have that barrier here in Kentucky, they do other places. But we would never want that barrier through a change of staff to delay their licensing here in Kentucky. So for military families, this is the best option. The cost for military families is astronomical. As they move about the United States, and the different states have different costs. So, and for instance, Texas sometimes takes 3 months to be licensed. And that's a huge burden for military families. So this reduces the effort for them, which they would have to do through otherwise traditional licensing. The reduction in barriers, states benefit from compact licensure by being able to address workforce shortages, emergency preparedness, and the enhancement of public protection, which is very important to the state licensure board, of course. The compact increases mobility of licensed respiratory therapists to fill critical healthcare staffing gaps, particularly in our rural and underserved areas. It enhances emergency preparedness by quickly deploying qualified respiratory therapists from other states. And it enhances public protection by establishing a coordinated database and reporting system among the member states. The licensing board's quick access to information regarding a licensee's credentials, adverse actions, and any significant investigative information improves our ability to protect our public health and safety here in the Commonwealth.
But speaking of military and compacts, we have General Bullard with us today, bringing us another compact bill. We've had a lot of success with those in the past. Question, so for the committee to hear, how many compacts, how many other states are entering into this compact with us?
So right now, I brought my little diagram with me so I could remember. I couldn't remember all. So right now we've passed it in 4 states. It was first introduced in January and passed in Washington, Montana, Iowa, and Alabama. There's only 6 states that do not have it in some sort of process. So we have all 7 states surrounding Kentucky are in the process of this. So it's moving into their legislature to be introduced. And we have 6 more states that still need to meet on it. So we have 7 states that have challenges that may not. That includes California and Oregon and Idaho and New York State. So those have challenges, so we don't know when that will move forward. But for us, for our surrounding states, it's already in the process. So It seems to be moving very quickly. We anticipated 3 years, but we think we'll have 7 states to form the compact, we believe, by mid-2026.
I believe these compacts are good for the state of Kentucky because it allows us to set our standards and what we think our standards and best practices are, and then at the same time identify states that have equal or greater standards than what we have and form partnerships with them. And I think that's the way for us to go, breaking down the barriers to workforce. Sir, do you have something to add to it?
You're right.
Just introduce yourself for
Yes.
the record. And
Yeah, my name is Dr. Kyle Mahan. I've been a respiratory therapist for over 20 years. I currently serve as manager for respiratory therapy, non-invasive cardiology, telemetry services, and special diagnostics at U of L Health Marion Elizabeth Hospital, as well as adjunct professor for respiratory therapy at Murray State University. I'm here today in support of the Respiratory Interstate Compact. Over the past 2 decades, I have personally held licenses to practice respiratory care in Arizona, Texas, Pennsylvania, and now here in Kentucky. While I was grateful for those experiences, holding those multiple single state licenses and meeting each state's demands, while duplicative, was also burdensome. As a respiratory therapy manager who's responsible for multiple clinical departments, I can say with confidence that the RCIC would make life significantly easier for both hiring applicants. Kentucky hospitals would have more candidates, including experienced therapists who may not have previously considered working in our state simply due to the licensure barrier. Right now, if every single respiratory therapy program at a college filled every single seat and retained every student to graduation, we still would not come close to filling all of the open vacant positions right now in Kentucky. Applicants would not be discouraged by the long process of applying for a brand new single state license. And I will say Kentucky was the fastest. I experienced 6 weeks, 4 weeks, almost 2 months, and then when I left Philadelphia, by the time I landed in Louisville, I already had a license to practice here. Our teams could extend offers more quickly and get new hires onboarded and working sooner. The benefits of this RCIC benefits our hospitals, managers, our community, and especially our patients. It eliminates duplicative applications, multiple sets of fees, unnecessary delays, and the streamlining benefit includes individual clinicians, hospital HR departments, and state licensing boards. A recent survey done by the KSRC and the KBRC showed that 98% of respondents supported joining the RCIC. The RCIC makes life easier for managers, easier for applicants, and ultimately better for our patients. Thank you.
And I also want to give kudos to the board because we've been going through a lot of board reports over the past interim, and 48-hour return time on your license. That's a good thing. Not every board is clicking that efficient. So I appreciate you for doing that.
Thank you very much. As we mentioned before, it is our top priority. It's our job. And I wanted to mention also that for the board and for the citizens of the Commonwealth, the major benefit for this compact licensure would be the ability to have that disciplinary action that we would know so that no bad actors are coming into the Commonwealth to practice and harm our public, and that's who we're here to protect.
All right. I don't see any questions or comments, so thank you all very much for your time today.
Thank you, Chairman Cook.
Stephanie Dietz for another board report.
Good morning. Stephanie Dietz from the 65th District, and I was asked to do a report on Marriage and Family Therapist Board. In talking to them, currently the Marriage and Family Therapist Board is contracted with the Department of Professional Licensing, which provides its administrative and fiscal services to the board. This includes providing staff, office, and meeting space, along with covering IT needs, such as the website, the back office, database, and online services. The board is also contracted with the Public Protection Cabinet's Office of Legal Services for its legal staffing. Currently, they say the board's administrative staff is sufficiently current. Their board is full. Their biggest challenge right now is licensees' misunderstanding of statutes and regulations and therefore not complying with those requirements. They say there is often a public misunderstanding of the licensing process. I asked, are there any legal or regulatory issues hindering their work? And they indicated that many of the interstate compacts require state boards to continually update their regulations. When changes are made at the compact level, and emergency regulations must be filed to stay in compliance. And this takes away from tasks that the board must perform. Additionally, the board lacks the formal statutory authority over the license portability, reciprocity, which tends to slow the process for out-of-state applicants becoming licensed in Kentucky. Interesting that they said, are there any emerging issues and trends that their board needs to be prepared for? And of course, they responded with the rise and use of artificial intelligence for therapy and the current lack of regulation over it, which could lead to potential harm to the public. So that's the update I was provided from them.
Thank you very much. The biggest, I think the most important thing for me on these board reports is that we've started to create relationships with the many different boards that are out there. And we're going to continue doing this over the next year, not only to try to just identify potential problems that are out there, potential problems that might be coming in the future, potential problems that the board is not doing right now. Any way we can do to help them. And then that in turn is going to help our workforce in cutting some of the red tape to help these boards operate and do what they're supposed to do. And we've already got positive things coming out. I believe Representative Callaway, with her relationship with the engineers and the land surveyors, I think they're talking about creating a scholarship. So I think we're already getting some positive measures coming out of it. So look forward to giving all the House members another board to talk about next year and continue this. And there's plenty of Senate members on a board too. There's plenty of them out there. So thank you, Representative Dietz. We have the Kentucky Horse Racing and Gaming Corporation with us today. We do have one that we have to vote on. Just as a reminder to the group that if you have a regulation, if there's no changes to it, no action is needed. But we do have one that has an amendment to it. So I'll let them come up. They can introduce themselves quickly and tell what the amendment is and if there's any questions on these two proposed regulations.
Thank you, Chairman. I'm Jamie Eads, President and CEO of the Kentucky Horse Racing and Gaming Corporation.
Ashley Bailey, Chief Legal Officer of the corporation.
And Drew Connors, Director of Incentives and Development for the corporation.
Thank you all for being here with us today. And if you want to just briefly tell us on 060 what the amendment is.
Thank you, Chairman. Following approval from the Administrative Regulation and Review Subcommittee, our staff noticed that there had been an error in Section 3 where a date had been changed from February 15th to December 31st, and again from June 15th to July 1st. That change was not subsequently made in subsection 3 of the previously approved suggested substitute. This also necessitated changes to some of the incorporated forms as noted in the general viewer's note on the last page of the new staff suggested substitute. We notified LRC when we noticed this issue and have now attached and presented the suggested substitute from the staff of the LRC for any questions and approval.
Are there any questions or comments on the amendments? Is there a motion for approval of the staff amendments? So moved. We have a motion and a second. Without we can do a voice vote on this. All in favor, say aye. Aye. All opposed, nay. Without objection, so ordered. Thank you all very much. All right, that concludes our last interim meeting.